Thank you all so much for joining us today. We are very excited to talk about a wonderful trial that's just been published in JACC. I'm Neha Pagidipati. I am a preventive cardiologist at Duke and very privileged to be an associate editor at JACC. And I'm thrilled today because we are joined by Dr. Steve Nicholls, who is a professor at Monash University and is the first author of the recently published Impact of Obicetrapib on Major Adverse Cardiovascular Events in High-Risk Patients, a Pooled Analysis. Dr. Nicholls, welcome.
Hi.
Wonderful. Well, let's get started. I think we have a pretty broad cardiology audience, and not everybody may be familiar with obicetrapib. Could you tell us a little bit about obicetrapib, how it works, and how it may be different from prior CETP inhibitors that people may have heard of?
Obicetrapib is a highly selective inhibitor of a factor called CETP, or cholesterol ester transfer protein. We know that CETP plays a really important role in lipid metabolism. It essentially moves esterified cholesterol from HDL to LDL and VLDL particles. And there's been a lot of interest in developing inhibitors of CETP for many years. And in fact, the earliest CETP inhibitors were developed because these agents can raise HDL cholesterol. What we learned with a number of those early programs was that we didn't see a reduction in cardiovascular events. The first of the agents had some toxicity, which was off target. We had a couple of other studies, which for a various number of reasons seemed to have no effect. And then we did have one CETP inhibitor program, which did have a modest, albeit significant reduction in major adverse cardiovascular events. And when we went back and looked at all of those studies, what we found was when a CETP inhibitor did reduce cardiovascular risk, it appeared to be related to lowering LDL cholesterol and non-HDL cholesterol, and actually wasn't related to raising HDL at all. And interestingly, that was very similar to the genetic studies. And the genetic studies in very large cohorts show us that if you have low CETP, you have low cardiovascular risk, but it's directly related to having lower LDL. And so what that tells us is that we may have had CETP inhibitors wrong right from the start, and that we should be developing these agents to lower LDL, which means we should be designing clinical trials in high LDL patients. And so what's really important about obicetrapib is it is highly selective, but it's also potent. And it's very effective at lowering LDL cholesterol, still raises HDL cholesterol a lot, does it at very small mass quantities. And so all of the clinical trials that have been designed in the obicetrapib program have been in patients who are treated with good lipid-lowering therapy, but still have high LDL levels, which is where we think the residual risk is.
And that's an excellent summary and part of a long story, I think, of being fooled by HDL in the past. Now, this is a pooled analysis. I think the first pooled analysis of the Brooklyn and Broadway trials. For people who aren't familiar, can you give us just a little bit of background about what the Brooklyn and Broadway trials were?
So early studies of obicetrapib had shown that it looked like it was pretty effective at lowering LDL cholesterol and potentially LPA, in addition to maximally tolerated statin therapy. Brooklyn and Broadway were two phase 3 lipid trials that were conducted in parallel. Brooklyn was a study of 354 patients who were treated with familial hypercholesterolemia and high LDL cholesterol levels, treated with either obicetrapib 10 milligrams or placebo for 12 months. And Broadway was a much larger study, a little over 2,500 patients, high cardiovascular risk, and that was defined as either having had ASCVD or familial hypercholesterolemia, again a 12-month study with patients being treated with obicetrapib or placebo. The primary endpoint, which was a lipid endpoint, in both studies was looking at day 84 or week 12. But as I said, these patients were treated throughout a 12-month period, and that's why we thought it would be important to be able to get an early look at cardiovascular events, which were all collected and adjudicated for these studies. Knowing that the large outcome trial Prevail, 9,000 patients, wasn't going to report out for some time.
Exactly. And what did you find with this early look at cardiovascular outcomes with obicetrapib?
Well, so the first thing we did was we reaffirmed the lipid effects of the agent. We saw that if you pulled the studies together, the obicetrapib group showed a 37.8% reduction in LDL cholesterol. We saw a 21.7% reduction in apoB. We saw a 140% increase in HDL cholesterol, very what we would expect. But we also saw a 32.5% lowering in LPA. Now, we didn't require these patients to have high LPAs coming in, so LPA was largely within the normal range, but we're seeing it go down about a third. We looked at two composite major adverse cardiovascular endpoints. The first was coronary heart disease, death, MI, stroke, and coronary revascularization. In that endpoint, we saw a hazard ratio in favor of obicetrapib of 0.77, but a p-value of 0.16, so it wasn't quite significant. But when we looked at a composite endpoint, which was more pure coronary heart disease, death, MI, and coronary revascularization, the hazard ratio was 0.68 with a p-value that was less than 0.05. And then we had pre-specified in that analysis that while this was still a relatively short study, that we were going to look at the effect in the first 6 months and the second 6 months of treatment. And that was really quite enlightening. For both of those composite endpoints, no difference between the groups early on, which isn't that much of a surprise, but a significant reduction in both composite endpoints from 6 to 12 months, a hazard ratio for that broader cardiovascular endpoint, including coronary and stroke events, of 0.6 with a p-value of 0.04. When we looked at that more specific coronary endpoint, after 6 months, the hazard ratio was 0.45 with a p-value of 0.003. And the longer you go, as we see in many of these studies, the curves continue to separate. So really interesting early data. The final analysis that we did do in this study was we looked at on-treatment levels of a range of different lipid parameters. This wasn't a mediation analysis. It wasn't about trying to understand what was driving the reduction in risk. It was just trying to understand what's the relationship between lipid levels and ongoing event rates in the patients in this study. And we see highly significant relationships between higher levels of LDL, apoB, non-HDL cholesterol, and LPA, and higher event rates, and an inverse relationship, lower HDL cholesterol being associated with higher event rates. So all the lessons we've learned from epidemiology still seem to hold 6-12 months into being treated with either OB or placebo, which is a really interesting finding. So early findings, obviously a much larger outcome trial to come, but gives us some encouraging signals to suggest that we are starting to see less events in the obicetrapib-treated patients.
I mean, that was a wonderful summary. Can you talk a little bit about that finding of a significant risk reduction after 6 months versus in the initial 6 months? How does that compare to some of the other lipid-lowering agents that we've seen in their cardiovascular outcomes trials? Is it similar?
Well, we certainly have seen in most kind of ASCVD studies, particularly on the lipid lowering side, that it takes some time before the event curves start to separate. And my rule of thumb is it takes about 6 or 9 months. So in some ways, it's not that surprising. We do start to see what appears to be a meaningful separation, not just a small separation. And maybe that does reflect the multitude of lipid effects that are going on with OB here in this cohort, encouraging early signs. And one of the reasons why I tend to be encouraged by seeing relatively early changes is that with chronic therapies, we know it's hard for patients to maintain adherence in the long term. It does suggest that even over the course of 12 months, we're seeing potential clinical benefit for patients.
You also outlined, there was significant reductions in LDL cholesterol and in apoB, but there seemed to be a little bit of a discordance in that there was more lowering in LDL cholesterol relative to apoB. Is that something that you've seen before with this agent and with other CETP inhibitors? And do you have a sense of what's going on there?
Yeah, it has, and it's been one of the challenges for the class is that there is a little bit of a disconnect between the degree of LDL cholesterol and degree of apoB lowering. In the very early stages of developing these drugs, it was actually largely due to the assay we were using. And the standard LDL cholesterol assays can be challenging in terms of accurately quantifying LDL cholesterol in the setting of a CETP inhibitor. So we've really moved more to this, what we call a preparative ultracentrifugation or beta quant assay for a more direct measurement of LDL cholesterol. We still do see some degree of discordance there. I would say that both the LDL cholesterol and apoB lowering that we see with this agent are greater than what we've seen with the other agents prior to this. And that's important for a couple of reasons. If you look at the CETP inhibitors that have gone before us, as I said, the first, Obicetrapib, had some toxicity, so that kind of gets wiped away. The second was an agent called Obicetrapib. Obicetrapib was a pretty modest CETP inhibitor, raised HDL cholesterol about 30%, didn't lower LDL cholesterol at all. So in retrospect, it's not that surprising. It had no effect on cardiovascular events. Evacetrapib, an agent that I know well, raised HDL cholesterol more than 100%. At the time, we thought the LDL was going down a similar extent to what we see here, but in fact, we were measuring LDL the old way. And so the LDL cholesterol lowering and the apoB lowering were less than what we see here. And that was a relatively small and short outcome trial, which got stopped for futility. So that's probably not that surprising. It probably needed to be much larger and much longer. And in fact, with anacetrapib, the one agent that did show a reduction in risk, that's exactly what they did. They had 30,000 patients and they followed them for a very long time. And in fact, their longer-term extension study showed even a greater benefit. So, and that probably is a reflection of the fact that the lipid lowering was there, but it wasn't quite as good as what we see here. So yes, we do see some discordance between apoB and LDL. These effects look much better than what we've seen with the other agents. And again, as I said, we've designed the outcome trial PREVAIL is in patients with high LDL cholesterol levels, and that we didn't see in the other CETP programs. We kind of made this assumption that, hey, if it's about HDL raising, then let's just bring a whole bunch of patients in whose LDLs look perfect. Well, turns out that's a really bad thing to do. And so that's one of the contributors to why a lot of those studies disappointed. Hopefully, these findings give us some hope for what we might see in the PREVAIL study when that reports out in the next few years.
I agree. Lots of reason for hope and optimism, and I think we're all waiting for that outcome study, but we'll have to wait a little bit longer. My last question for you is, did you find the degree of risk reduction after 6 months somewhat surprising given the degree of LDL lowering? If we often think based on CTT, if we think about 1 millimole per liter reduction in LDL cholesterol leading to like a 22% risk reduction, here you saw like double that for something similar. So I would love to hear your thoughts on what's going on there.
Yeah, I mean, the clinical trialist in me is going to be cautious. I think we saw a similar thing with the PCSK9 inhibitors. We saw two pooled analyses of alirocumab and evolocumab early studies that suggested that the hazard ratio was going to be 0.5, and it turned out to be 0.85 when you got into the legitimacy of a really long, large clinical trial. I hope Obicetrapib works. I think it'd be great for patients. But I think if it does, it's going to be a hazard ratio that is more in the contemporary kind of range rather than what we see here. These are relatively small numbers of patients. It's relatively short studies, and so the event numbers are relatively small. So my take-home message is to be optimistic about the pattern of what we're seeing rather than the magnitude of what we're seeing.
Perfect. I think that's the exact take-home message that we at JACC saw as well, but it's still very exciting early signals, and we were thrilled to publish it. Dr. Nicholls, thank you so much for taking the time to talk to us about this exciting study, and we look forward to working with you again in the future.
Thanks for having me.